In Module 3 of Oral Manifestation of Systemic Diseases, we will be discussing about endocrine disturbances. Be it in oral pathology, oral medicine, oral surgery, physiology, biochemistry, when you deal with endocrine disturbances, you need to have a list of interrogations in mind. Yes, you will. And you have to clarify them even before we could proceed further with it. So the first query which should pop up in our mind is, what are hormones? Why are they named so? Now, hormones are chemical messengers. They are produced by specific organs. They are released into the blood circulation and they act at different sites on different target tissues, exerting their actions. The word hormos is a Greek word, okay? The word hormos is a Greek word. It means assured to exert an activity, alright? So that is what hormones is about. So what are the functions of hormones? They have a wide range of functions, starting from metabolism, growth, reproduction, metabolism of all the macromolecules, proteins, lipids, carbohydrates. Yes, the hormones play a very vital role in all these physiological processes of the body. So what are the types of hormones? Hormones could be an amino acid derivative. Say, you know that thyroid hormone, T3 and T4 is an amino acid derivative. Catecholamines, epinephrine, norepinephrine, dopamine, they are also amino acid derivatives. Both the thyroid hormones and catecholamines have tyrosine in them. Likewise, serotonin, melatonin, they have tryptophan in them. Histamine will have histidine in it, right? So, it could be amino acid derivatives or it could be even lipid derivatives similar to the cholesterol structures, testosterone, cortisol, glucocorticoids. They are all lipid derivatives, or they could be long chain of polypeptides, protein chains like anterior and posterior pituitary hormones like antidiuretic hormone, oxytocin. Yes, so even the biochemical composition of hormones is very much varied, okay? So what are these endocrine glands? What are glands? Glands are nothing but an organized collection of secretory epithelial cells. During the development, the glands begin as epithelial proliferation attached to the surface. As they grow further, they move away from the surface, but few glands remain attached to the surface by means of ducts, and they are called as exocrine glands. But few other glands, their ducts degenerate and they lose their continuity with the surface, but still they keep exerting their actions, they keep releasing the hormones. These are called as endocrine glands. So, how are endocrine glands different from exocrine glands? Exocrine glands have ducts. Endocrine glands are ductless glands, but both release hormones, have varied effects on various structures by releasing hormones, by releasing chemical substances, chemical messengers. So, with this basic knowledge, we will also touch upon a few examples of endocrine glands. Okay, the most important of the endocrine glands are the master gland, that is the pituitary, followed by hypothalamus, the thyroid gland producing T3, T4, thyroxine, parathyroid glands producing the parith hormone. Pituitary gland will have the anterior lobe and the posterior lobe. The anterior lobe produces the growth hormone, adrenocorticotropic hormone, thyroid stimulating hormone, follicle stimulating hormone, luteinizing hormone, prolactin, okay? And the posterior pituitary, as you all know, produces the oxytocin and antidiuretic hormone. How about the adrenal glands? You know the anatomy of an adrenal gland. It's just capping the kidneys, right? The two adrenal glands, they cap the kidneys. But if you take a cross section of it, you will find the adrenal medulla and the adrenal cortex. From the adrenal medulla, the catecholamines are produced. What are the catecholamines? Epinephrine, norepinephrine and dopamine. When you come to the cortex has three zones: zona glomerulosa, zona fasciculata and zona reticularis. So, zona glomerulosa produces the mineralocorticoids, that is your aldosterone. and zona reticularis produces the all the corticosterols, cortisols, glucocorticoids. Okay. So that is about adrenal glands. Pancreas, you know, the islet or islet cells of Langerhans produce the insulin. Ovary, progesterone, estrogen, and testis produces the testosterone. There are few other glands, some they just move out of existence because they become vestigial, non-functional after a period of time. They work only transitory. Few glands like pineal gland is also an endocrine gland. It's very important for the sleep-wakefulness cycle. It is important for the melatonin production, right? And how about the thymus? The thymus produces thymopoietin, which is very important for the maturation of T lymphocytes. Yes? So these are the other miscellaneous glands. Now, when we speak about endocrine glands, I understand this slide looks very busy. I will make it very simple for you. Now, we've seen these are the endocrine glands, right? Adrenal gland, the thyroid gland, the pituitary gland, the hypothalamus. Now, remember, for instance, I say adrenal cortex produces glucocorticoids, which means that it doesn't take the entire autonomy or authority to produce glucocorticoids. It is regulated by the anterior lobe of the pituitary gland, which secretes ACTH, adrenocorticotropic hormone, which in turn is regulated by the cortisol releasing or the corticotropin releasing hormone from the hypothalamus. So you see the regulatory pathway for the adrenal glands to produce cortisols. It needs the help of the anterior pituitary and hypothalamus through the secretions of CRH, the cortisol releasing hormone, and ACTH, adrenocorticotropic hormone. Likewise, all the other glands also have this hypothalamo-pituitary axis regulating their secretion. So this is what you need to understand. But why they have to be regulated? Why can't they directly secrete into the bloodstream? You need to know that the hormone levels keep fluctuating. In physiological conditions, there might be a minor fall, there could be an increase. As it falls and as it increases, the homeostasis, the balance has to be maintained by higher regulatory centers. So that is why the hypothalamus and the pituitary gland always works in coordination with the other endocrine glands. Alright? So this is how it works. The hypothalamus, the pituitary gland, the anterior and the posterior lobe, and the target organs. It could be the adrenal gland, the thyroid gland, the parathyroid gland, the ovaries, testes. Yes? Okay. So I have just segmented the picture such that you can visualize it better. So you find from the anterior lobe, you have the ACTH, thyroid stimulating hormone, the growth hormone, somatomedins, which is secreted in response to growth hormone, the prolactin, the follicle stimulating hormone, luteinizing hormone. They are all secreted by anterior pituitary gland. The posterior pituitary, the melanocyte stimulating hormone, oxytocin, antidiuretic hormone. Okay, they are all synthesized by the posterior pituitary. Fine. And accordingly, they regulate the secretion of the cortisols, the T3, T4, testosterone, estrogen, progesterone, all the main endocrine hormones. Okay, now coming to the disturbance in these endocrine gland secretions having an impact on the oral and maxillofacial regions. These are the topics we will be focusing in the discussion. We know that deficiency of the growth hormone causes dwarfism in children and acromegaly in adults. Likewise, excess produces gigantism in children, and when it occurs in adults, we call it as acromegaly. Likewise, thyroid hormones, hypothyroidism and hyperthyroidism can occur. When it decreases in children, we call them cretins, and in adults, it is Mxedema. When there is an increase in thyroid hormone levels, they end up in Graves' disease or thyrotoxicosis. Likewise, parathyroid hormones, Hypoparathyroidism reduces calcium levels, which manifests as tetany, and hyperparathyroidism manifests as Brown's tumor, what is known as osteitis fibrosa cystica. Next is adrenocorticotropic hormones, okay, the cortisol. Hypocortisolism, when there is a decrease in the level of the cortisol, patient will have what is known as, this is a magnified view of what I was speaking in the previous slide, as how the pituitary gland, both the anterior and the posterior lobe, have an influence on the other endocrine glands which secrete the hormones. Now, though we have a list of endocrine glands and the hormones synthesized by them, more to our concern as what hormones will have an impact on the oral and maxillofacial region when there is a disturbance in their secretion. Those alone we will be focusing on this discussion. Starting from the growth hormone, deficiency causes dwarfism in children and acromegaly, relatively rare in adults. And excess of growth hormone secretion, results in gigantism in children and acromegaly in adults. Next in line is a thyroid hormone. Deficiency causes hypothyroidism. We call when, if it occurs in children, we call the children as cretins. Hypothyroid children are called cretins, and hypothyroidism in adults is called as Mxedema. Analogous to it, hyperthyroidism, excessive thyroid hormone production causes Graves' disease and thyrotoxicosis. Parathyroid hormones deficiency causes decreased calcium levels in the blood, manifests as tetany, and increased parathormone in the blood, causes increased calcium levels, ends up in Brown's tumor, what is more scientifically called as osteitis fibrosa cystica. Yes. Then adrenocorticotropic hormone, the cortisol secreted by the adrenal glands, secreted by the adrenal cortex. If there is a deficiency in the cortisol production, it results in Addison's disease, and if excess of cortisol is going to be produced, patient ends up having Cushing's syndrome. We'll discuss few objective type questions related to these topics. Which of the following is seen in acromegaly? Retruded maxilla, retruded mandible, prognathic maxilla, prognathic mandible. It's obviously prognathic mandible. Yes, so we've seen that acromegaly is excess in the production of growth hormone, excessive synthesis of growth hormone in adults, because the same growth hormone, if it's produced excessively in children, we call them as gigants. The condition is called as gigantism. A little more about growth hormone. You know that the growth hormone is produced by the anterior lobe of the pituitary gland. As the name implies, it helps in the growth of the skeletal structures, right? Muscles and also the visceral organs, all the internal organs of the body. Just know that it is also involved in lipolysis and it maintains the blood glucose levels. So these are the functions of the growth hormone. Once secreted from the anterior pituitary gland, it exerts its effects directly on the somatic and visceral structures or through the liver. It acts on the liver, produces what is known as IGF, insulin-like growth factor, also called as somatomedin C. These are the other names of insulin-like growth factor, which will also have a growth hormone-like functions. It's a very good indicator of growth hormone production in our biochemical analysis. Now, what are the other parts shown in this illustration? There is something which is regulating the growth hormone. What it is? It is the growth hormone releasing hormone from the hypothalamus. Suppose if the growth hormone is going to be produced in excess, immediately somatostatin is produced by the GIT. That will have an effect on the pituitary gland, instructing the pituitary gland that you have to reduce your growth hormone synthesis. Likewise, if there is going to be a decrease in the growth hormone production, then immediately the hypothalamus will produce the growth hormone releasing hormone, which will act on the pituitary gland, anterior lobe of the pituitary gland, more specifically the acidophilic cells of the pituitary gland, instructing it to produce more growth hormone, so that there is a balance in the growth hormone secretion at the blood level, at the serum level. Okay, so this is the regulation of growth hormone and the functions of growth hormone. So what happens if there is an imbalance in the growth hormone production? Okay. So if there is going to be an increase in the growth hormone production, yes, it results in gigantism or acromegaly or acromegalic gigantism. And if there is going to be a decrease in the growth hormone production, it will result in dwarfism or acromegaly. Now, what is the difference in all these terminologies? Yes, so gigantism is excessive production in children, acromegaly in adults, and acromegalic gigantism is there is an excessive growth hormone production in the childhood, but it continues even after the closure of the epiphyseal cartilage, and the growth hormone continues to be synthesized excessively even in the adults. In that condition, we call it as acromegalic gigantism. Likewise, when there is a decrease in the growth hormone in children, you call them as dwarfs. In adults, it's relatively rare, you call it as acromegaly. Alright, so I was telling something. What is this? This is what I was telling about the epiphyseal closure. Now, epiphysis is that region or a part of a long bone. Now, this is epiphysis, this is diaphysis, and again the end is epiphysis. But this portion is the epiphyseal plate, what you see near the metaphysis. This epiphyseal plate remains unossified in the children and the adolescent. Once the bone growth is complete, it undergoes complete ossification, resulting in the formation of a thin epiphyseal plate. Okay. Now this event of when we say the bone formation is complete, when the epiphysis or the epiphyseal plate, that small strip of unossified bone completes its ossification, that we call it as epiphyseal closure. So for adults, the epiphyseal closure has already occurred. The bone growth has completed. The bones do not increase any further in length. Okay. So when there is, so this is an yardstick to describe these two words, gigantism, acromegaly. Likewise, dwarfism and acromegaly. When there is going to be an increase before the epiphyseal closure, you call it as gigantism. And if it's going to occur after, if the increase is going to occur after the epiphyseal closure, we call it as acromegaly. Now, hope you are clear with the terminologies. No way you should get confused, because imbalance in growth hormone results in all these conditions, but each one has a different meaning. Okay. Now, let's see how a patient with acromegaly presents himself. You see how thickened his skull is. There is a protruding of the supraorbital margins, ridges, and there is a prognathism of the jaws. There is enlarged organs starting from the heart, cardiomyopathy, the liver, visceral organs, even the stomach, the diabetes, pancreas shows enlargement. Then there is a broadening of the hands. The fingers of the hands, the toes of the feet are all enlarged. You find the coarse facial features. Yes, all these are very symptomatic of a person with acromegaly. The patient develops headache, diplopia, lethargy, blindness. Okay, so these are all the signs and symptoms of acromegaly. Now, this is a cartoon where you find adult with acromegaly. He has excessive growth hormone, insulin-like growth factor is also produced more, where there is an excessive growth of his hands, feet and jaws. Hands, feet and jaws, you see how they are? Very much visible. He is huge. Likewise, these are normal children. And you see the cartoon of a gigantic child. This is gigantism, where there is an excessive action of IGF-1 before the closure of epiphyseal growth. He is a gigantic child. Now, what happens to your oral manifestations? What happens if the mandible is going to be enlarged? There is going to be spacing between the teeth. A problem arises if he is going to be a very elderly patient. The dentures will become very tight, right? So all these malocclusion, all these are things which you can expect. Thickened lips, thickened tongue, macrodontia, true macroglossia could be seen in these patients. Now this is another case study. Let's see what it is about. A 44-year-old female patient presents with large swelling in the posterior mandible, and it's of 3 months duration. Radiographically, a radiolucent lesion, yes, we find that, of the mandible occurs extending from the right premolar to the left incisor region, yes. And evidence of root resorption and tooth mobility, buccal, lingual, cortical plate expansion. There's a proliferation of spindle cells with extravasated blood and multinucleated giant cells. Okay, now let's see what this case study is about. A 44-year female patient presents with a large swelling in the posterior mandible. It's of 3 months duration. It extends from the right premolar region to the left incisor region. That is buccal and lingual cortical plate expansion. And you find that tooth mobility is also present in this patient. Histopathology shows spindle cells, extravasated RBCs and multiple multinucleated giant cells. I think they have given few more information for us to arrive at a diagnosis. So here you find the histopathological picture where there are numerous multinucleated giant cells. So the spindle cells which they are telling, the hypercellular stroma is contributed by the fibroblast. Here you find the biochemical analysis as shown increase in calcium levels, the alkaline phosphatase levels and the Parath hormone. They are way high beyond the normal range. However, the phosphorus level is within the normal limits. It's only around 3.9 milligram per deciliter when the normal is about 2.4 to 4.1 milligram per deciliter. So what could you think of? So immediately the diagnosis which should strike you is hyperparathyroidism, right? So this is a case of hyperparathyroidism. You know that Parath hormone is produced by the parathyroid glands. Parathyroid glands are just 4 small glands which are very important for the maintenance of iodized plasma calcium levels, which in turn is very important for the development of teeth, the bones, even for the neuromuscular excitability, cell-to-cell contact, cell-to-cell adhesion, cellular motility, membrane fluidity, integrity, blood clotting. So there are so many functions of calcium for which Parath hormone is very important to maintain the regular blood calcium levels. We'll see how it is. So, in normal conditions, when there is a low blood calcium level, what does the parathyroid gland do? It will produce the Parath hormone. and it will instruct the bone to mobilize calcium from the bone. It will give instruction to the kidney to increase the reabsorption of calcium into the circulation, and it does not directly act on the intestines, but it will promote the formation of vitamin D in the kidneys. Okay, and this vitamin D indirectly will increase the absorption of calcium from the intestines. So by all these ways, the serum calcium levels are brought back to normal. So when the calcium levels are low, the pareth hormone secretion, the production is increased. This is what happens normally. Now just vice versa to what I have told. When there is a high blood calcium levels, the pareth hormone levels will decrease. Automatically there won't be any mobilization of calcium from the bone, there won't be any reabsorption of calcium from the kidneys, neither will there be any absorption of calcium from the intestines, resulting in very low or stabilizing the calcium levels. We cannot say that the calcium levels becomes lower than the normal. The high calcium levels are brought to a normal range. So now you know how the homeostasis of the plasma calcium levels are maintained. So when it becomes very low, pareth hormone is released, brings back the calcium levels to normalcy. When the calcium levels are very high, the pareth hormone is not released, and again the high levels of calcium are brought back to normalcy again. Now the question is, what happens in abnormal parathyroid gland? In an abnormal parathyroid gland, let me refine this description of abnormal parathyroid gland. Pareth hormone could be produced in excess, or pareth hormone production could be decreased if it's going to be produced excessively, as in the case of hyperplasia of parathyroid gland, neoplastic condition, could be an adenoma, could be a carcinoma. Then there will be an excessive production of pareth hormone, or any other pathologies can also inhibit the pareth hormone release. It will accordingly cause hyperparathyroidism or hypoparathyroidism. So what happens in this case, say if the patient is having adenoma of the parathyroid gland, some carcinoma of the parathyroid gland, then there's going to be an excessive production of pareth hormone and excessive production of calcium is going to occur. So let's see what happens in hyperparathyroidism. So I have retained the biochemical report of the previous case study so that you have all the values etched in your mind. You need to know the normal values, normal range of serum calcium, alkaline phosphatase, the phosphorus and the pareth hormone levels for you to identify any derangement from the normal values. Alright? So what happens in hyperparathyroidism? The patient presents with painful bones. Yes, the patient often develops fractures. Generalized osteoporosis will be present. Next is renal stones, what you call as nephrocalcinosis. You know that when there is an increase in parathyroid hormone levels, it causes the increase in calcium ions. So the calcium gets deposited in most of the subcutaneous tissues of the body, in the sclera, in the dura mater, in the calvarium, okay, and also in the kidneys more specifically, where renal stones begin to form, the condition being called as nephrocalcinosis. Patient will have a lot of abdominal pain, abdominal discomfort. So, next thing is abdominal groans and psychic moans. So you see these rhyming words describing the clinical manifestations you see in hyperparathyroidism: bones, stones, groans and moans. So bones, what happens to the bones? Increased tendency to fracture, There is a disturbance in the calcium phosphorus metabolism. So generalized osteoporosis can occur. Painful bones will be present. Stones, increased calcium deposition occurs in the kidneys, resulting in nephrocalcinosis. Abdominal groans because of duodenal ulcers and cyclic moans. The patient will have a sense of lethargy, mental confusion, fatigueness. So all these are clinical manifestations of hyperparathyroidism. Now coming to the radiographic features. Patient presents with characteristic ground glass appearance of the mandible or the pepper pot appearance of the skull. Why does this occur? Because there is an alteration in the trabecular pattern. There is a marked variation away from the normal trabecular pattern. Subperiosteal resorption of the phalanges takes place, especially the phalanges, the terminal phalanges of the middle and the index finger. And when you see the radiograph in long-standing cases, multilocular or unilocular radiolucent lesions, pseudocysts form in the mandible, and when those lesions are grossed and taken out, the specimen will be dark reddish brown in color because of the increased hemosiderin pigmentation, and that's why the name given is Brown's tumor. Yes. So degeneration occurs within the bone, and these cystic degenerations are soon replaced by fibrous tissue. Fibrosis occurs, and hence why the name osteitis, fibrosis cystica. Okay, occurs in the bone, degeneration followed by fibrosis, leaving behind cystic areas. Hence the name osteitis, fibrosis cystica. So these are the radiographic manifestations which you see in hyperparathyroidism. So remember these few words: ground glass appearance, pepper pot appearance, Brown's tumor, osteitis, fibrosis cystica, and the other name is von Reckling-Gossen's disease of the bone. Okay, and histopathologically, what do you find in the histopathology? You will find numerous extravasated RBCs and increased hemosiderin deposits, multinucleated Jane cells, along with a richly fibrous and cellular connective tissue stroma. What are the cells? You will have sheets of fibroblasts, spindle-shaped cells. So in a cellular connective tissue stroma, you will find abundant numerous multinucleated Jane cells and extravasated RBCs. That is the histological picture of hyperparathyroidism. So this is what I was telling. Extravasated RBCs, you find a lot of hemosiderin pigment being deposited. You have a cellular connective tissue stroma. So you call it as von Reckling-Gossen's disease of the bone. So all what you know is parathormone controls the calcium levels in the blood. But do not forget that the regulation of calcium is also monitored by vitamin D individually and calcitonin produced by the parafollicular cells of the thyroid gland. What happens in vitamin D? So vitamin D is helpful for the synthesis of calcium, in the sense it helps in the absorption of calcium from the intestines. Calcitonin just analogous to what vitamin D and parathormone does. It will prevent the mobilization of calcium from the bone. It will prevent the reabsorption of calcium from the kidneys, from the renal tubules, and it will also inhibit the absorption of calcium in the intestines. So it has an antagonistic function. So So what could be the most common cause of secondary hyperparathyroidism? Now we have introduced the word secondary. Then there should be something called as primary hyperparathyroidism. Yes? So primary hyperparathyroidism is to do with all pathologies associated with the parathyroid gland itself. Parathyroid adenoma, hyperplasia, carcinoma. Okay? This can cause an increase in parathormone levels and an increase in calcium levels. In secondary hyperparathyroidism, what could be the cause? It's end-stage renal disease. How is end-stage renal disease correlated with disturbance in the parathyroid hormone secretion? Yes, you should know this. How is vitamin D synthesized? From cholecalciferol, yes, which undergoes hydroxylation in 2 steps, one in the liver and the other part in the kidney. In liver, 25-hydroxylase, hepatic 25-hydroxylase gets in the hydroxylation process, followed by in the kidneys, the renal 1-alpha hydroxylase hydroxylates the 25-hydroxycholecalciferol into 1,25-dihydroxycholecalciferol. Ultimately, the active form of vitamin D is formed, calcitriol. Now, why are we speaking about vitamin D synthesis when the question is about secondary hyperparathyroidism? Just because the kidney and the liver are very significant in the development or in the synthesis of vitamin D, which again has its effect on maintaining or the production of calcium. Any defect or any disorder affecting the kidney and the livers will affect vitamin D synthesis. It will again affect or lower the serum calcium levels. If the calcium levels are going to go down because of a defective synthesis of vitamin D, because of a defect in the kidneys, because of renal osteodystrophy or end-stage renal disease, then this will indirectly cause an increase in the parathyroid hormone levels because there is low levels of calcium in the blood. So that's why it is called as secondary hyperparathyroidism. Okay. Loose connective tissue stroma that shows numerous multinucleated giant cell is seen in all of the above. You know, hyperparathyroidism, cherubism, central giant cell granuloma, all these lesions histopathologically, they will show extravasated giant cells with multinucleated extravasated RBCs with multinucleated giant cells. So, hyperparathyroidism may cause all of the following except increased blood calcium levels. No, hyperparathyroidism will show increased blood calcium levels. How about supernumerary teeth? Do you find supernumerary teeth in hyperparathyroidism? No. So that is a probable answer that supernumerary teeth is a feature which is not seen in hyperparathyroidism. Giant cell lesion of the bone, loss of lamina dura around the teeth are characteristic feature of hyperparathyroidism. The next question is exophthalmos, nervousness, tachycardia, heat intolerance and hypertension. They are all features of, yes, the answer is hyperthyroidism, right? So hyperthyroidism is excessive production of thyroid hormone. Thyroid hormone is produced by the thyroid gland. It's very, very important for maintaining the basic metabolic rate in any individual. Just not that, it also supports the normal maintenance of the growth and the maturation of all the body tissues. So in hyperthyroidism, patient experiences intolerance to heat, exophthalmos, nervousness, tachycardia and hypertension. So this is how the thyroid hormone synthesis is being regulated. You all know that thyroid hormone is being produced by the thyroid gland. But for it to produce thyroxine, active form of thyroid hormone, the hypothalamus has to release the TRH, thyroid releasing hormone, which will act on the anterior pituitary gland to release thyroid stimulating hormone. This thyroid stimulating hormone will act on the follicular cells of the thyroid gland to produce thyroxine. So the hypothalamic pituitary axis has to work in a stabilized fashion for the thyroid gland to produce thyroxine. So from here you know what they speak about the positive feedback and negative feedback control. If thyroid hormone levels are going to fall down, the positive feedback loop is going to work, increasing the secretion of TRH and TSH, increasing the thyroid hormone levels in blood, bringing it to normal. When there is a very high level, then the negative feedback loop will work. So the TSH, TRH has to reduce its levels so that the thyroxine secretion decreases and comes to normalcy. So this homeostasis is maintained by the thyroid releasing hormone and the thyroid stimulating hormone from the hypothalamus and the anterior pituitary gland. So what happens when there is a total derangement of the normal thyroid hormone levels in the blood? It can either increase aberrantly, as in Graves' disease and thyrotoxicosis, where we call it as hyperthyroidism, but the patient will have intolerance to heat, very fine air, weight loss will be present, edema of the feet peripherals will be present, tachycardia, increased systolic blood pressure, menstrual changes, and enlarged thyroid, facial flushing, exophthalmos, proptosis is nothing but bulging of the eyes. All these are features which is encountered in hyperthyroidism. What happens in hypothyroidism? Hypothyroidism is decreased thyroid hormone production. Decreased thyroid hormone production in adults is called as Mxedema. In children, they are called as cretins. So you will find, what does this cartoon tell? The patient will be intolerant to cold, cannot resist cold. Here, she's wearing a sweater, a neck gaiter, scarf, gloves. Yes, you find that. They will have receding hairline. Hair loss will be present for this patient. Bradycardia and weight gain can occur as later changes. Along with that, they will have a thick tongue, slurred speech, anorexia, constipation. All these are features of hypothyroidism, which you find in Mxedema, right, and cretinous. Low thyroid levels in children is seen in cretinism. Mxedema is in adults. A condition caused by excess of steroid hormone cortisol in the blood levels caused by pituitary tumor secreting ACTH. So, you know that an increase in cortisol secretion is called as Cushing's syndrome, right? But I wish you notice this. This is caused by pituitary tumor secreting ACTH, because any problem or any adenoma, hyperplasia of the adrenal gland as such can cause a primary disease condition. Even in that, cortisol level can increase. But in this case, it has occurred as a secondary phenomenon where there is a tumor of the anterior pituitary. The anterior pituitary is producing the ACTH, which is nothing but adrenocorticotropic hormone, which will have its effect on adrenal gland to produce the cortisol. So anywhere in the regulation, the balance could be impaired. Okay. So this is what I was telling. The hypothalamus produces the cortisol releasing hormone, which will act on the anterior pituitary to produce adrenocorticotropic hormone, which in turn will act on the zona reticularis of the adrenal cortex to produce cortisol, and cortisol will exert its metabolic effects. Why do we need cortisol? Cortisol is very important to face very stressful conditions. It inhibits inflammation. It inhibits immune response. It is involved in lipolysis, proteolysis, and also gluconeogenesis. So, corticosteroids, steroids, when do we say that? Use that. So, even in the recent times, in the COVID times, in the global pandemic times, these steroids have become indispensable. When the patient is totally unstable, the first option is the steroids are given. But these are endogenous steroids we are speaking. Glucocorticoids are given in the form of medications for the patients. So there again the function is to inhibit the inflammation, to inhibit the immune response. Okay, so that is what I wanted you to understand here. Now, what is this question about? Addison's disease typically causes hypertension? No, it causes hypotension. Causes hypopigmentation? No, it causes hyperpigmentation. It is an autoimmune disease and steroids are contraindicated? No, not specific for this condition. So what is Addison's disease? As I already told, Addison's disease occurs because of decrease in cortisol levels. It is hypocortisolism. Patient will have arthralgias, myalgias, hyperpigmentation because the decreased cortisol levels will cause the ACTH to stimulate the melanocortin receptors in the melanocytes to produce melanin, which in turn will produce increased pigmentation of the skin. The patient will also have nausea, vomiting, diarrhea, fatigueness, thinning of the axillary, pubic hair, vitiligo, hyperpigmentation and hypotension. So all these are features of Addison's disease. You see the hyperpigmented gingiva and the tongue. Arthralgia, sometimes flexion contractions can occur for the patient as in this case. So Cushing's syndrome, there is increase in the cortisol levels, which could be because of adenoma of the adrenal gland, increase in ACTH levels, or it can even be because of a tumor affecting the hypothalamus, which is increasing the CRH, cortisol releasing hormone. So anywhere, again the cortisol levels could be deranged because of any of these factors. So this is a classic appearance of a patient with Cushing's syndrome. I told that one of the function of cortisol is lipolysis, mobilization of fat, that is increased deposition of fat in the central portions of the body, especially in the dorsocervical spine region, behind the neck. Patient will have a buffalo hump as you see in this case. Truncal obesity, reddish purple striae will be present in the lower abdomen. Moon facies, very thin limbs. Patients are often described as a lemon being stuck onto a toothpick because the limbs are thin but the body is seems large because of unwanted fat deposition. Patient will also have emotional disturbance, enlarged sella turcica, osteoporosis, thin wrinkled skin and the other features of Cushing's syndrome. So this a cartoon comparison between Addison's disease where there is a decrease in cortisol level and Cushing's syndrome where there is an increase in the cortisol level. So here you find dark brown, bronze pigmentation of the skin, the changes in the distribution of the body hair, postural hypotension will be present, hypoglycemia will be present for these patients and along with GI disturbance and weakness. Here you find the fat deposition on the face, on obeseness on the abdomen, lower abdomen, increased susceptibility to infection, there is increased sodium and fluid retention, edema. So here you have an outright comparison. What happens to the calcium levels? It's increased in Addison's disease, decrease in Cushing's syndrome. The blood glucose levels, increased in Cushing's syndrome, decreased in Addison's disease. Potassium, what happens to the potassium levels? Decreased in Cushing's syndrome, increased in Addison's disease, and sodium levels are decreased in Addison's and increased in Cushing's syndrome. Okay, at least on this comparative basis, you should know the features of Addison's disease and Cushing's syndrome. Now, deviating away from the regular multiple choice questions, let's try to answer these one-word questions. Calcitonin is secreted by parafollicular cells of the thyroid gland. Epinephrine is secreted by adrenal medulla. To recapitulate, Adrenal gland has adrenal medulla and the adrenal cortex. The medulla produces the catecholamines, epinephrine, norepinephrine and dopamines. The adrenal cortex has three parts, zona fasciculata, reticularis and the glomerulosa. The glomerulosa produces the mineralocorticoids, your aldosterone. The reticularis produces the glucocorticoids, the cortisols. Iron is essential for the formation of thyroxine. Acute adrenal insufficiency occurring because of acute septicemia like streptococci, meningococci, pneumococci infections. You call it as Waterhouse-Friderichsen syndrome. This has been asked a couple of times in your competitive exams. Hyperparathyroidism results in what is known as tetany, lowered calcium levels. What happens in tetany? In tetany, there is lowered serum calcium levels below 8.5 milligram per deciliter. You know that calcium is very, very important for neuromuscular excitability, membrane fluidity, membrane integrity, for blood clotting. It's important for cell-to-cell adhesion, cell motility. So, when tetany manifests, the patient presents with laryngospasm, carpopedal spasm. Two important signs which you need to remember is the Chvostek's sign and the Trozier sign. In Chvostek's sign, a slight tap in the facial nerve, the zygomatic region, anterior to the ear, auricle, will cause twitching of the lips and spasm of the facial muscles on that side. It occurs ipsilaterally. Okay? That's because of the lowered calcium levels. In Trozier sign, if you leave the cuff, sphygmomanometer cuff inflated for more than 3 minutes, the patient will develop this sign, Trozier sign, where there is adduction of the thumbs, what you see in this picture. There is flexion of the wrist and the flexion of the interphalangeal joints. So this is very characteristic of tetany when there is lower serum calcium levels. The patient will also develop other symptoms like muscle cramps, abdominal pain, perioral tingling sensation. Alright? So this you must not forget in your clinical practice, because when a patient walks into your clinic with a lot of candidal infection, with a poor periodontal status, generalized recession, generalized multiple abscesses in the oral cavity, you understand that the patient is in a state of complete immunosuppression. You can either think of oral manifestations of diabetes mellitus. Another condition which should also strike you is HIV, okay? Acquired immunodeficiency syndrome. Now coming to diabetes mellitus, the patient will also complain of decreased salivary secretion. The salivary glands are affected. Burning mouth syndrome, xerostomia, geographic tongue. Once the salivation is decreased, there is increased tendency for caries, right? So all these are oral manifestation of diabetes mellitus, which mainly occurs because of decrease in insulin secretion secreted by the hilate of Langerhans cells of the pancreas. Insulin regulates the blood glucose level. Blood glucose levels are very high in these patients because of lowered insulin levels, insufficient to regulate the blood glucose levels. Alright, so with this we are winding up with the endocrine disturbances, which will cover up the module 3 of oral manifestation of systemic diseases. But remember not to forget to log on to the other 2 modules of oral manifestation of systemic diseases, where we have dealt about the disorders of carbohydrate, lipid, protein metabolism, vitamin deficiency and also disturbances in the mineral metabolism. Thank you.